the introduction of ISS, there has been a major advance in the field of prognostic biomarkers that led to a revision which was still beyond expectations. 1Q gain is a high-risk cytogenetic feature among newly diagnosed myeloma patients. And first of all, 1Q gain has been integrated into Mayo Additive Staging System. And then the second revision of the ISS by the EMN under the umbrella of European Union funded Harmony project. And both provide enhanced prognostic accuracy, aiding treatment decision and also patient management. Clinicians should consider using these systems alongside traditional staging methods for a more comprehensive evaluations. And at last IMS, we presented our retrospective analysis to validate this novel score and evaluate its impact on the outcome of newly diagnosed myeloma patients. Our single-center uniform real-world database study also confirms the prognostic role of the new mass as a reliable and reproducible method to powerfully predict the prognosis of patients with newly diagnosed multiple myeloma. Based on the results of our study, the presence of 1Q gain confers poor outcomes and also provides robust proof of the revision of 1Q gain in the mass. And furthermore, mass is able to characterize outstanding prognostic and ultra-high-risk patients not possible in the earlier ISS and ISS models. This is a big chance for our patients. So at last IMS, we presented one of our prospective studies that post-induction that is related with the post-induction MRD. Post-induction MRD within, but not outside of marrow among transplant-eligible patients with myeloma is currently recognized, as all we know, as a poor prognostic. And an emerging number of studies are evaluating MRD within the context of cytogenetic risk. And in this study, we aim to quantify circulating plasma cells by NGF in apheresis product and compare with marrow MRD and outcome according to cytogenetics. Our 454 subsequent new diagnosed myeloma patients were included in this prospective study. Cytogenetically high risk was observed in 19% of the total cohort, and post-induction CR was achieved in 18% of our patients. And following mobilization, graft MRD and marrow MRD was undetectable in our patients. Graft MRD is in 48% of our patients, marrow MRD 13% of our patients. Having undetectable marrow MRD estimates like a 2 years PFS of 92%, and this was excellent. And the patients are, and then we divided our cohort into 4 groups according to marrow MRD status and cytogenetic risk stratification. And Kaplan-Meier curves related as significant differences in median PFS among these patients. And we saw that if the patient with standard risk and achieved marrow MRD negativity, the median PFS was not reached. This was good. And also we did a multivariate analysis, and that showed marrow MRD and post-induction CR to determine PFS independent from age, ISS, and also cytogenetic risk. In conclusion of our study, our real-world triplet drug induction-based experience shows post-induction marrow MRD to be correlated with PFS, although observed less frequently, achieved post-induction MRD negativity, marrow may ameliorate the poor prognosis of high risk. With improvements in induction, it may be possible to achieve more frequent negative MRD and thus analyze the impact of each cytogenetic risk group, for example, 1Q implication separately. We will see. In Turkey, treating multiple myeloma can present several challenges, unfortunately. Access to specialized care is one of our problems. Ensuring access to centers with expertise, multiple myeloma diagnosis and treatments can be a challenge, particularly in rural areas. And the other is access to newer, more effective treatments of myeloma. Also may be limited due to factors such as cost, reimbursement policies, and regulatory barriers. And one other is increasing awareness among patients and healthcare providers about myeloma symptoms, diagnosis, and also treatment options is essential for early detection and optimal management. And also the socioeconomic disparities may impact access to healthcare service, medications, and also supportive care, effective treatment outcomes for patients with myeloma. And one other issue is access to supportive care services such as palliative care, pain management, and psychosocial support, and may vary depending on geographic location and healthcare infrastructure. So addressing these challenges requires a multifaceted approach involving collaborations between healthcare providers, policymakers, patient advocacy groups, and pharmaceutical companies to improve access to care, enhance patient education, and also expand treatment options for multiple myeloma in our country. So, treating multiple myeloma in low and middle income countries can be challenging due to limited researchers and access to expensive medications. And they should use standard treatments such as chemotherapy, immunomodulatory drugs, and proteasome inhibitors as appropriate based on the patient's condition and available resources. And also option for cost-effective alternatives whenever possible, including generic version of medications or those available through international aid programs, and incorporate corticosteroids never be forgotten, such as prednisone or dexamethasone, which are relatively inexpensive and can be effective in managing myeloma symptoms, and prioritize supportive care measures to prevent and manage complications such as bone pain fracture and hypercalcemia. This includes bisphosphonates for bone strengthening, and also integrate palliative care early in the treatment process to address symptom management, psychosocial support, and end-of-life care, improving patients' quality of life. These are also important, and encourage participation in clinical trial whenever possible to access novel treatments and contribute to advancing myeloma care in these countries, and foster collaboration with international organizations, academic institutions, and also pharmaceutical companies to access medications, expertise, and resources for myeloma treatment, and provide ongoing education and treating of healthcare providers on the latest advancement in myeloma treatment and supportive care practice, and establish patient support programs also can be done as provide financial assistance, transportations, and psychosocial support, addressing the socioeconomic barriers to accessing care also, and advocate for improved access to essential medications, diagnostic tests, and healthcare services for myeloma patients through policy changing and public awareness campaigns. And also by implanting healthcare providers in these countries can optimize the management of myeloma and improve outcomes for patients despite research constraints. Unfortunately, we have no access to CAR T-cell therapy instead of clinical trials in Turkey. But there are a few centers that we know are attempting to produce academic CAR Ts, and I hope we will reach this excellent treatment option in the near future.